Okay, welcome to those who've already joined this meeting. We're fortunate to have three very excellent speakers. We have, in order of their speaking, Mr. Stephen Billing, who's a cardiothoracic surgeon in Wolverhampton and has had a long time interest in AF ablation. We have Dr. Syed Hassan, who is an EP cardiologist at St Bartholomew's Hospital. He too has an interesting AF ablation, and he's also one of the growing group of EP cardiologists who are interested in including the surgeons in the discussion with regards to AF management, both generally and specifically in concomitant surgery. And then we have Dr. Edward Soltesz from the Cleveland Clinic, who's just rejoined, who's going to tell us about some work he's done with the left atrial appendage occlusion clip in coronary patients who are in AF. So Dr. Soltesz is dressed for work as he has some surgery in preparation now, and hopefully we'll get him to the operating room in time. So I think we were probably waiting for a few more people. So if I can get a nod from Scott that there are more people joining, then we can make a start, because I think it'd be useful to have the time at the end for questions, where we can have a discussion, in particular before Dr. Soltesz dashes off. All right, shall we make a start? Okay, so Mr. Billing is going to start first. I'm going to be telling us about reasons of why we should be doing it, but they also allude to what's actually happening in the UK, which is may surprise some of you. So he's going to talk about the surgeon's perspective, in particular in the UK. Thank you, Stephen.
Hello, I'm Steve Billing. I'd like to thank the organiser of this webinar for the opportunity to present today. I shall be discussing the current state of surgical AF ablation in the UK. I'm Steve Billing. I have one disclosure. I thought I should start by reviewing the indications for AF ablation, and the focus here will be on surgical AF ablation concomitant with other cardiac surgical procedures. From my perspective, this is a once-in-a-lifetime opportunity for a patient with atrial fibrillation to have a potentially curative procedure at the time they are having other surgery. This gives the potential to improve symptoms, to preserve left and right ventricular function, to reduce the thromboembolic risk, and even to prolong life. Of course, atrial fibrillation is not a benign disease. We are well aware that there is a stroke risk, but moreover, AF-related stroke results in a higher in-hospital mortality than other stroke and a lower rate of discharge to home. AF also has a bidirectional relationship with both heart failure and myocardial infarction, such that there is a higher incidence of AF in heart failure and vice versa, and similarly with myocardial infarct. Moreover, there's the potential problem of atrial functional mitral or tricuspid regurgitation, which can occur with long-term fibrillation. As an illustration of how non-benign AF can be, this is data from a VA study looking at death and other complications following the first diagnosis of atrial fibrillation in VA patients. And the scary part of this data, of course, is the 50% 5-year mortality rate. There are some clear guidelines to guide the introduction of concomitant AF ablation during other cardiac surgery. In the European 2020 guidelines for management of AF, concomitant ablation is considered to have a class 2A indication. The STS in their guidelines for surgical treatment of AF would consider it a class 1 indication at the time of mitral surgery, but also a class 1 indication for concomitant ablation with closed cardiac surgery, albeit at a lower level of evidence. And finally, the Heart Rhythm Society, in conjunction with other bodies, generated a consensus statement on ablation of atrial fibrillation. And here they considered concomitant ablation to have a class 1 indication during open, i.e. mitral valve cases, and a class 1 or 2A indication for closed cardiac surgery. So I believe the real question actually should be, firstly, why not perform an AF ablation if a patient with AF is coming to surgery? And secondly, if performing an ablation procedure, why not perform a full maze to give the best possible chance of sustained sinus rhythm? We have a little data. A survey of US surgeons was presented at the AATS back in 2011. And this looked firstly at the number of patients who underwent an AF ablation procedure as a concomitant procedure in relation to different other forms of cardiac surgery. Encouragingly, among the mitral valve patients, 50% had an ablation procedure, but this rate dropped to 28% as a concomitant procedure with coronary bypass grafting. The survey also asked the surgeons what were the reasons why perhaps they would choose not to offer an ablation procedure. And here in these stacked bars, the grey component is the extremely important reasons. And for 30% of such surgeons, this was increased complexity. Over 30% felt it would add time. There were concerns about the reproducibility of surgical AF ablation results, about the lack of consensus regarding which particular ablation procedure to perform, and other related concerns. In the UK, GIRFT has been performed in both cardiac surgery and more recently cardiology, and the methodology in getting it right first time is to identify any unwarranted variation between different units, then to explore the local context in relation to those variations, and ultimately to use these findings to drive best practice on a national level. Now, if the UK were indeed leading the way in surgical AF ablation, one perhaps would expect that the available data should drive a similar uptake of ablation across the individual units in the UK. And so we have looked at that. I am one of a group of surgeons forming a working group to promote the uptake of surgical AF ablation in the UK. We conducted an email survey of all UK surgical units, and thus far we have responses from 50% of the units. In those units responding, the incidence of atrial fibrillation in cases coming to surgery was 13.4%. So we might suspect that the number of ablation cases would relate merely to case number. And as you can see in the first plot here, there is not a relationship between unit size and the number of annual ablation cases. So perhaps surgical AF ablation rests mainly among the mitral valve surgeons, and then we would expect the number of AF ablation procedures to correlate with the number of mitral valve cases. Again, unfortunately, this does not appear to be the case. Digging further into our responses, we looked at which proportion of patients undergoing mitral valve surgery would be offered and have performed an AF ablation procedure. And as you can see from this chart, there are 25 to 30% of units performing a reasonable portion of AF ablation procedures in mitral valve cases. Unfortunately, we do not know the incidence of AF in those mitral valve cases. But more than half of the units to respond thus far have a rather low incidence of AF ablation, even in mitral valve cases. So I postulated what the surgeon's concerns or thoughts might be when thinking about concomitant AF ablation. Firstly, is it worth the hassle? It adds to the complexity and time of the operation, and also adds to the complexity of post-op care. They may be concerned about added clamp or bypass time. Perhaps concern about the chance of successful achievement of sinus rhythm, or increased risk of perioperative mortality, or even heart block requiring a pacemaker. We have the answer to some of these questions, mainly relating to risk. The ATS Expert Consensus Guidelines posed several questions pertaining to surgical AF ablation and then looked at data in a meta-analysis fashion to try to find answers where available. Here are the more pertinent questions. Firstly, does concomitant AF ablation increase the perioperative morbidity? And it's clear from the evidence that it does not. Does ablation reduce the perioperative stroke or TAA rate? Again, it does not, but this is not the aim of the procedure. Does it reduce late stroke rate? The data here are more difficult due to the nature of the studies incorporated in meta-analysis, but I believe the conclusion would be maybe it does reduce the late stroke rate. Does ablation improve the symptoms of AF or the quality of life? Yes, it does. Does it improve short-term survival? Yes. And again for long-term survival? Yes. And here is the forest plot from that paper showing that surgical AF ablation favors long-term survival. In Wolverhampton, we have looked at our results because we were keen to answer the question of where is the place for a maze procedure in high-risk patients. So we did a retrospective cohort study over an 8-year period. We chose to designate high-risk patients as those being 70 years of age or older, with atrial fibrillation and having at least 2 cardiac procedures, quite apart from any AF-related procedure. There were over 300 patients during this period, of whom 71 had a maze and almost 200 had no procedure at all. The mean log Euroscore in the maze group was 10, confirming that this is indeed a high-risk population. However, there is of course selection bias here. This is a retrospective study, and the patients having no treatment did have a higher log Euroscore than the maze group. Nonetheless, the maze group had a mortality of only 1.4%, indicating that addition of the maze has not increased the mortality risk. At 12 months, when we looked at the sinus rhythm rate, 80% of the maze patients were in sustained sinus rhythm, which I think we would deem a satisfactory result. Moreover, there was no increase in the rate of complete heart block by addition of a maze procedure. And I haven't given the figures here, but on average between the groups, there was no difference in bypass time or clamp time. Looking at the longer term results from the same study, we demonstrated that actually the maze group, when compared with the no procedure group, had a survival advantage and also a functional advantage in terms of NYHA Class 1 status. So I believe the question we should come to is, in which cases would it be reasonable to omit a concomitant AF ablation procedure? If the duration of persistent AF is very prolonged, then the chances of a successful ablation go down. Similarly, with very dilated atria, the chances of successful ablation are lower. On the other side of the coin, the risk of adding an ablation procedure may be higher in the case of redo surgery or other adhesions, particularly due to the difficulties of going behind the heart for some of these lesions. However, it is possible in that setting to use cryoablation for those parts of the maze, and achieve a full modified maze. So I consider it a relative contraindication. There may be cases where there are genuine access difficulties to the pulmonary veins. There may be other instances of extreme surgical difficulty for whatever reason. And also there may be a need in individual cases to absolutely keep the operative time to a minimum due to other risk factors such as carotid disease, renal impairment, or problems with myocardial protection. But I believe that these contraindications represent only a minority of patients who could be offered surgical AF ablation. So to return to the primary question, are we leading the way in surgical AF ablation? Well, certainly several UK cardiac units have very reputable rates of concomitant ablation and are achieving good results. However, there is huge variability in uptake of this procedure across the UK. I think there is probably a need for greater awareness of both the benefits and guidelines for surgical AF ablation, and at the same time a need to share experience between the units, since I suspect that the success rate and presumed risks are different from those that can actually be achieved. Thank you very much.
Thank you, Steve. As I mentioned earlier, we'll have all the questions at the end. But if you have any questions you wish to ask, you can post them in the chat, which you'll find at the right-hand side of your screen, and we'll work through them one by one. So for now, we'll move straight on to Dr. Syed Hassan, who sadly has not left work yet at St. Bartholomew's, and he's going to give us the cardiologist's perspective. Thank you.
Good evening, everyone. My name is Syed Hassan, consultant cardiologist and electrophysiologist at Bart's Heart Centre. Firstly, thanks to the SCTS and sponsors Atricure for inviting me to present this evening. I'd also like to thank my co-speakers this evening. And I've been asked to talk to you today about AF attitudes and experience, the cardiologist's perspective, why we need to ablate. Heard a fantastic talk from Steve already this evening, and I'd really just like to run through a quick talk giving a cardiology perspective on why we're entering an era where ablation is becoming so important for the management of atrial fibrillation. So if we look at the natural history of AF, we know that the lifetime risk for developing AF is high, 1 in 4 for men and women aged over 40 years. And this prevalence increases rapidly with age and is set to continue to increase by 2.5-fold by 2050. AF affects 1 in 25 adults over 60 and 1 in 10 adults over 80, and these numbers are likely to continue to increase. Say a high proportion of us will be diagnosed with AF at some point in our lives, and there are many, many patients who have been diagnosed and even more who remain undiagnosed. And this number is going to increase due to population aging significantly. What's more interesting is that there is a changing landscape in terms of cardiovascular disease and how patients are presenting to hospital. So historically, heart attacks, stroke, and heart failure have been the main cardiovascular presentations. However, these numbers of these specific conditions have significantly decreased recently. And in the first cardiovascular events are now more commonly, certainly in the UK, neither MI nor ischemic stroke. Patients with AF have not just got symptoms of palpitations, but they are much more prone to developing strokes, heart failure, ischemic heart disease, sudden cardiac death, and have not only an increase in cardiovascular mortality, but even all-cause mortality as demonstrated in this paper from 2016. We can see in this chart here the top 10 reasons for hospitalization in AF patients on the left-hand side before they were diagnosed with AF, and on the right-hand side following diagnosis of AF. And we can see that following a diagnosis of AF, the type of conditions that patients are presenting to with hospital are much more common and significant than prior to their diagnosis. So this is important in terms of the costs of AF hospitalization and the surrogate for hard outcomes. What about the mortality risk? Well, subjects from the original cohort of the landmark Friedman heart study were found to have a 1.5 to 1.9-fold mortality risk, and this was even after adjusting for pre-existing cardiovascular conditions. So this data re-emphasizes that AF really is not a benign condition and needs active management. The RELY trial, which was a large landmark study looking at rivaroxaban, looked at the causes of death in the population of patients with atrial fibrillation. And we can see that progressive heart failure and sudden cardiac death were two of the main causes of death, along with stroke and other unknown cardiovascular causes. Non-cardiovascular causes formed a much smaller percentage of causes of death. We then move on to the cost of AF, which is becoming increasingly important. Back in 2000, this was approximately 1% of total NHS expenditure, amounting to 459 million. But over time, we know that AF rates have increased significantly, and it was 5.9 in 2001 to 6.9 per 1,000 person years in 2013. So a dramatic increase already, which has probably increased and will continue to do so further. There are more widespread of expensive drugs such as NOACs and ablation, so AF is becoming more costly for our health service. And these costs are made up of hospital admissions primarily, but also drug treatment and primary care visits. In this chart, we can see the fall in MI and heart failure from an Australian publication in 2019. And in blue, you can see the increasing number of hospitalizations from atrial fibrillation, which continue to increase, whereas heart failure and myocardial infarction rates drop. So what about interventions? What are the interventions with a prognostic impact? The initial management of AF is fairly well established. We record an ECG to make the diagnosis. We record their symptom score, their risk score for stroke. We get them started on AF sort of anticoagulation, and then we decide whether we're going to adopt a rate control strategy or a rhythm control strategy based on the AF type and symptoms. And then we consider treatment of underlying disease as well, and consider referral for, say, coronary artery disease or heart failure. This slide is important, and it summarizes some of the key catheter ablation studies for atrial fibrillation. It helps us look at mortality, which is here randomized controlled trials with level of evidence A, so the highest level of evidence. And this data is derived from multiple RCTs or from meta-analysis. And what we can see is that in some of the landmark trials, catheter ablation, for example in Castle AF or ATAC, had a huge impact on reducing mortality in patients with atrial fibrillation. Castle AF was a study, randomized controlled trial published in the New England Journal of Medicine, which looks at the prognostic impact of catheter ablation in patients with AF and heart failure. But also, it has a significant impact on the reduction in hospitalizations. Cabana was a study looking at mortality in patients with atrial fibrillation, randomized to either a medical strategy or catheter ablation strategy. And we can see that a combination of mortality and hospitalization was significantly reduced with catheter ablation. And other non-randomized controlled trials have also demonstrated a significant reduction in mortality. Now, if we look at antiarrhythmic medications, we see that there is a significant increase in mortality when we look at RCTs and meta-analyses looking at different drugs which are in common use. So, for example, 111% increase in mortality when we use dronedarone, 123% increase with sotalol, which is a commonly used antiarrhythmic, 173% increase in mortality with the use of amiodarone. And hospitalizations may also be significantly increased as a result of the medications that we use to achieve rhythm control in this group of AF patients. So medications used for AF are certainly not benign and can cause significant complications. And when someone is in doubt about the prognostic benefit of catheter ablation, it is important that they are made aware of the increased mortality with nearly all antiarrhythmic agents. This slide shows the number needed to treat in some of the landmark cardiology studies, not just for AF, but across heart failure and other conditions. And we see here on the y-axis the number needed to treat, i.e. the number of patients who receive this specific intervention that we need to treat in order for one patient to have a benefit. And what we can see here is that Castle AF, which, to remind you, was the study looking at catheter ablation of atrial fibrillation in patients with AF and heart failure, has the lowest number of patients needed to treat when compared to any other of the cardiology landmark studies. And we're talking about drugs, interventions such as resynchronization therapy, ACE inhibitors, beta blockers. So these are fundamental trials, but with a catheter ablation of AF in heart failure, only a small number of patients need to be treated in order for one patient to have a benefit. We then go on to look at the main cardiovascular RCTs and reduction of mortality and hospitalizations. And again, Castle AF shows a very small number of patients needed to be treated with a catheter ablation in order to gain a benefit. And here you can see Cabana, another study looking at catheter ablation versus medical management. 15 patients needed to be treated to have one patient get a benefit. Now, if you compare these to some of the heart failure and pacing trials and some of the fundamental coronary intervention trials, we see that, a significantly larger number of patients need these interventions before we cause benefit. And finally, looking at the recent Cabana study, again, patients with atrial fibrillation treated with an ablation or drug therapy, the beneficial effects of ablation in terms of recurrence of arrhythmia happen quickly within 6 months and are persistent up to 4 years. So ablation for atrial fibrillation not only reduces hospitalization, not only improves patient symptoms, but clearly has a mortality benefit in certain groups of patients. So is it cost effective? Well, we know that AF has a high incidence. We know that the costs associated with atrial fibrillation are significant. And we also know that assessment of atrial fibrillation can be complex. For example, the upfront costs of an ablation for the procedure, the future reduction in healthcare costs with reduction in hospitalizations, the quality of life benefits, the benefits to society, and the freedom from AF versus a reduction in AF burden all need to be factored in to see whether this is cost effective. And the best way to do this is to use QALYs or quality adjusted life years. And one QALY is 1 year in perfect health, or 2 years with a 50% improvement in quality of life. ISA is an incremental cost effectiveness ratio, so comparing two treatments and the outcomes of the two treatments to determine the additional costs per quality. So interventions which have high costs but a better quality of life survival and less morbidity are still potentially beneficial. So in the NICE HTE, the Health Technology Assessment, interventions costing the NHS, if they cost less than £20,000 per quality gained, this is thought to be cost effective, and interventions which cost up to £30,000 per quality gained might, with certain conditions satisfied, be cost effective. And in terms of catheter ablation in atrial fibrillation and flutter, there was a systematic review which stated that if the benefits of catheter ablation are maintained over the remaining lifetime of the patient, then the cost of effectiveness of ablation appears clear. And these findings were robust, and the quality cost per additional quality was between £7,700 and £7,900. So very much falling into the cost-effective group according to the NICE Health Technology Assessment. So what about patients having ablation at the time of surgery? Well, this study looking at preoperative AF by the procedure type found, looking at 79,000 Medicare beneficiaries in the States, found that 28% of patients undergoing cardiac surgery had atrial fibrillation. How many of these patients received interventions? Of mitral valve surgery, 38% had surgical ablation, and in non-mitral valve surgery, only 16% had surgical ablation. So a total of 22% of patients undergoing cardiac surgery in the States, and a large number of patients did not undergo surgical ablation. But why? This is the quality for a surgical maze for a cut and sew, between £1,000 to £3,000. So surely that's a no-brainer in the context of valvular disease. And if you use high-intensity focused ultrasound-assisted surgical ablation, again, a very low cost for adding this intervention as opposed to no treatment. So it was deemed to be cost-effective when added to mitral valve surgery or CABG. A surgical ablation at the time of mitral valve surgery showed an ISA of 4,446 Canadian dollars, which is about 3,800 US dollars per quality compared with valve surgery alone. And this quality carries on through different ranges. So the sensitivity analysis suggests that 58%, 73%, and 89.3% of the simulations of the maze strategy are cost effective at a willingness to pay threshold. Again, this publication from Spain, €7,000 for surgical ablation versus no ablation when adding on to mitral valve surgery, and 16,000 if you look at the cost of catheter ablation. So even more reason to perform a surgical ablation, which we know is effective and we know leads to better outcomes at the time of surgery. So finally, we look at concomitant AF ablation during CABG, and this Medicare analysis of 3,745 patients with AF undergoing CABG in 2013. Concomitant surgical ablation occurred in 17%, and a very significant benefit for mortality after 90 days when you add in surgical ablation at the time of CABG. The risk of a device implantation, incredibly low. So there's no doubt that there's a mortality benefit with concomitant CABG at the time of, concomitant AF surgery at the time of CABG. So in summary, AF is a growing epidemic. AF leads to not just symptoms, but reduced quality of life, increased hospitalization, and more importantly, increased mortality. The costs from AF are continuing to increase exponentially, and AF ablation, catheter and surgical ablation, is associated with clinical benefit. Surgical ablation of atrial fibrillation concomitant to valvular heart disease or CABG is extremely cost effective, is significantly underused, and has very good data to support its use. So I urge you all to review this data and think about adding surgical AF ablation to concomitant surgery. Thank you.
Thank you, Si. That was a very interesting insight. Just for those in the audience that have never heard of high-intensity focused ultrasound, sadly, it's no longer available. It was pretty effective, but it really causing isolating the posterior left atrial wall, so the box lesion. So now, finally, we move on to our final speaker, who is a great pleasure to introduce, who's Dr. Edward Soltesz from the Cleveland Clinic. He's between cases at the moment, but just before we all started, he went off to do the huddle, which we call the brief in the UK. So hopefully we won't detain him too long, but long enough for you to ask some questions. So Dr. Soltesz is going to tell us about the improved outcomes in coronary artery surgery in particular in patients with AF and left atrial appendage occlusion using the clip. Thank you.
Hi, I'm Dr. Edward Soltesz. I'm the Surgical Director of the Kaufman Center for Heart Failure and Recovery, as well as the Director of Cardiac Surgery Affiliate Programs at the Cleveland Clinic. Today, I'd like to discuss with you improving outcomes in CABG patients with atrial fibrillation, utilizing the left atrial appendage exclusion clip. Here are my disclosures. Approximately 5 to 11% of all patients requiring cardiac surgery and up to 22% of older surgical patients have pre-existing atrial fibrillation. Now, pre-op AFib contributes significantly to mortality, stroke, length of stay, and readmission after cardiac surgery. In fact, it also contributes to survival post-surgery. Non-AF related cardiac surgery presents a unique opportunity to concurrently address comorbid AFib and improve outcomes. Now, among patients with AFib, approximately 90% of strokes can be attributed to thrombi originating from the left atrial appendage. Concomitant surgical left atrial appendage management is recommended both by the revised 2019 ACC as well as 2017 Society of Thoracic Surgeons guidelines. This can be achieved by either excision of the appendage and suture closure of the stump, suture ligation at the base, internal suture exclusion, as well as staple excision at the base. Additionally, the left atrial appendage exclusion clip can also atraumatically occlude the appendage at the base. Now, trials of concomitant suture and staple left atrial appendage occlusion with coronary artery bypass surgery demonstrated incomplete occlusion, subsequent increased risk of thromboembolism, and a high incidence of procedure-related adverse events. However, the EXCLUDE trial demonstrated the safety and feasibility of the Atricure left atrial appendage occlusion clip, with 98% successful occlusion at 1 year and no device-related mortalities or adverse events. Long-term follow-up studies showed the durability of this device, but there is still a paucity of contemporary data to demonstrate the impact of left atrial appendage exclusion via this epicardial clip on outcomes when added to isolated coronary artery bypass patients who have atrial fibrillation compared to those who just have coronary bypass surgery alone. Therefore, our objective was to evaluate the incremental benefit of adding this left atrial appendage clip occlusion to coronary artery bypass surgery in patients with preoperative atrial fibrillation. We wanted to measure the effect on postoperative thromboembolism rates, all-cause mortality, readmission, as well as hospital costs. Our data were obtained from the Medicare Standard Analytic Files dataset of hospital inpatient and outpatient claims. Medicare is a federal health insurance program in the United States that provides coverage for legal residents more than or equal to 65 years of age, as well as those less than 65 years of age with certain disabilities, and all patients who have end-stage renal disease and require dialysis or transplant. Because this is publicly available data, this was exempt from institutional review board. Our inclusion criteria utilized ICD-10 codes to code for coronary bypass surgery patients, as well as those who did or did not have an epicardial clip placed. We included those older than, equal to, or older than 65 years of age, and we required baseline persistent or paroxysmal atrial fibrillation, and no atrial fibrillation ablation along with the CABG. We excluded other major concomitant cardiac surgery. As I mentioned before, we excluded ablation for atrial fibrillation, as well as any other surgical left atrial appendage management. We also excluded patients who had a coronary artery bypass surgery in the past year or who have had a heart transplant. So in the end, we started with little over 83,000 coronary bypass procedures between 2015 and 2017, and we identified little over 75,000 isolated CABGs and 3,600 CABGs with the left atrial appendage clip. When we selected out pre-existing atrial fibrillation among these patients, our study cohort was little over 3,200 isolated CABGs and 930 CABG plus clip plations. If you look at unadjusted patient characteristics, you can see that there was slightly more persistent atrial fibrillation present in those who received the clip versus those who did not, as well as there was more heart failure, hypertension among those who did not receive a clip, but no difference in stroke or history of stroke or history of peripheral embolism. We then adjusted and did a propensity score matching, excluding 11 patients from the cohort, and were able to match quite nicely 3,269 patients with isolated CABG and 930 patients with coronary bypass surgery with the clip placement. Here you can see our standardized difference plots both before and after waiting. 30-day adjusted outcomes show no significant difference in mortality, length of stay, or readmissions between the group of patients who had coronary bypass surgery alone or those who had coronary bypass surgery with a left atrial appendage occlusion clip. There was, however, a slightly increased risk of postoperative atrial fibrillation among those patients who had a clip placement, as well as a slightly increased risk of pacemaker placement in those who have had a clip. When we look at thromboembolism rates, we see that there was a 26% reduction in thromboembolism with those who had coronary bypass with the clip compared to those who did not have a clip, with the subhazard ratio of 0.74. When we look at the distribution of thromboembolism, we see that the majority were ischemic strokes, but some were peripheral embolisms and TIAs as well. Early mortality showed no difference between those patients who had a clip versus those who did not, with a hazard ratio of 1.05 that was not significant. However, when we look at late mortality, that is at 90 plus days, we see a divergence and a significant difference with the hazard ratio of 0.04 in favor of those patients who had a left atrial appendage occlusion clip compared to those who did not, of all the patients undergoing coronary bypass surgery. There was also a statistically significant difference in readmissions, with fewer readmissions among those who had a clip at 90 days to 1 year, as well as beyond 1 year. When we look at hospital costs, there was no difference in index costs, likely because of the initial upfront cost of the left atrial appendage occlusion device. However, when we look at 1 year costs, we see a trend toward lower cost in those patients who had a clip placement. Obviously, this is a retrospective observational study with a significant amount of selection bias. There was no documentation of oral anticoagulation use. However, we feel that this probably would not change the outcomes. Future studies clearly need to focus on a younger cohort, and therefore a different database would be required, as the Medicare database is specific for those over 65 years old. And we would also want to look at the clip versus other techniques to determine if there is a significant advantage inherently in clip occlusion. And finally, obviously, randomized controlled trials would be important. And we'll see in a few seconds that the LAAOS III trial results, which were just reported, although slightly different patient profile group than ours, do lend support to our study as well. If you look specifically at what the LAAOS III showed in terms of stroke or systemic embolism, you can see a statistically significant decrease in both stroke or systemic embolism rate in those patients who had left atrial appendage occlusion clip placed during any cardiac surgery, not just coronary artery bypass surgery. Looking at the rates of ischemic stroke, there was a statistically significant lower stroke rate among patients with left atrial appendage occlusion clips, but no difference in death or hospitalization for heart failure. Now, there is a significant difference between our study data and the LAAOS III trial. Our patients are slightly older, CHEDS 2 VAS score is slightly lower, and paroxysmal atrial fibrillation dominates our patient group. History of ischemic stroke, however, between the two groups is very similar. Again, as I noted before, our patient study data was all isolated coronary bypass surgeries with no ablations, and those in the LAAOS III trial had 20% coronary bypass surgery, and 34% of them had concomitant ablation. In our group, all patients had left atrial appendage occlusion device versus only 15% used the occlusion device compared to other forms of managing the left atrial appendage in LAAOS III trial. Stroke as well as death can be seen different between the two groups, but in line with what we would believe to be a significant effect of left atrial appendage occlusion, and that is to say a decrease in stroke and a trend toward decrease in death in LAAOS III. Friedman's study from JAMA in 2018 also lends support to our study. Friedman looked at over 10,000 patients from a combined STS Medicare database, looking at coronary bypass surgery, mitral, and aortic valve replacements, and showed that concomitant left atrial appendage occlusion had lower thromboembolism rate as well as mortality at 3 years. So in summary, I would say that coronary artery bypass outcomes in patients with pre-existing atrial fibrillation are better with concomitant left atrial appendage occlusion clip. There is increased long-term survival, decreased thromboembolism, decreased readmissions, and there is no difference in complications. Treatment costs are similar over time, with understanding, of course, that the initial outlay for the device seems to be recaptured in lower costs ongoing. We would recommend that non-atrial fibrillation-related cardiac surgery presents a unique opportunity to concurrently address comorbid atrial fibrillation. And we would recommend clip occlusion of the left atrial appendage in patients who are undergoing coronary bypass surgery with known AF because it improves outcomes. Obviously, we must ask ourselves, is this consistent with other literature? And it appears it is. Would oral anticoagulation data change the result? We don't believe it would, as it would bias in the opposite direction. And finally, the economics of left atrial appendage occlusion need to be investigated further, as there are additional techniques that can exclude and or manage the left atrial appendage as well, and these need to be compared in a comparative effectiveness study.
Very much.
Thank you for your attention.
Thank you. That was a very interesting talk. So we have some questions. We'll go in slight reverse ordering in case Dr. Soltesz has to disappear to the operating room. But I'd like to make a comment to the audience. We've heard a lot about the studies and the evidence. We've had 1B, 1A evidence and lots of things. But I just wonder how many in the audience, and I know this because I've asked the question several times, who would not put a lemur to the LAD and who would not relieve aortic stenosis with either a TAVR or a surgical prosthesis? Because the evidence for that is 1B, not 1A. But the evidence is equal or even better for doing something to the appendage or to atrial fibrillation. So I'll start with the last question that came up, asking, and specifically for Dr. Soltesz, asking about any possible risk using the clip with a graft, a venous graft to the obtuse marginal, looking at relation to long-term fibrosis or compression.
Yeah, that's a very good question, and we have not seen that in any of our cases. Of course, we're not doing angiograms on everyone postoperatively, but clinically we have not seen that. It's been described in a few occasions, and typically with sort of very long, redundant venous grafts in that area, but it's an extremely rare event. To be truthful, we do see some fibrosis in the area, and it really is variable among different patients. We have seen sometimes significant fibrosis after, for instance, we do an LVAD and put in a clip-on at the time of heart transplant, but in other situations there's minimal adhesions present. So I think the concern about kinking a venous graft, really there's no evidence to support that, and I think it certainly is used as a reason why someone doesn't want to do put the clip on, and I think a lot of the times in surgery, to your point, just prior to this, is that there are a lot of errors of commission are usually much better tolerated than errors of omission. So we have one opportunity to get it right, as we sort of have heard, I think, from all these presentations, and the surgical theater obviously offers that opportunity.
Thank you. Can I ask you a question just to follow on from that? Do you put the clip first or the graft first in position?
So I do the clip first, and most of the time I'm actually doing an ablation first. So I do a full ablation, get around the pulmonary veins on the right and on the left, excise the tip of the appendage and do the ablation up to the left superior pulmonary vein, and then I take the ablation clamp across the dome of the left atrium, connecting to the right superior pulmonary vein, and that takes a good 20 minutes. 25 minutes, and then once I'm done with that, I put a clip on, then commence bypass surgery. And once I'm all done with the bypasses, I go through a small Sondergaard's groove incision to do the mitral annular connecting lesion and the floor lesion.
Thank you. So we're going over the questions that came in. So the next one probably direct to Stephen Billing, and I can guarantee I will have a slightly different answer to this question. The question is from Mohammed Osman, who asked, what is the limit of atrial size for considering ablation?
Well, firstly, thank you for the question. In my presentation, I deliberately didn't give a size. I think it would be fair to say the success of the maze is inversely related to atrial size. You still have the option of an LA volume reduction procedure, which perhaps my namesake might quite like. 5 centimeters is the figure I have in my mind, where from my reading of the literature, the results of a maze are less. But in my own practice, I don't have a rigid cutoff. If I get someone with a giant 8 or 10 centimeter atrium who's been in AF for 20 years, I think probably less value. But 5 or so, I think the chances of success start to dip. Steve?
Yeah, I think, yeah, I've had 2 cases in my it's a rather long career at the moment, where they presented with dysphagia due to a mega atrium. So reducing the atrium is helpful in many cases. And we don't know about this. We'll come to the next one we said about the atrial myopathies, which have been interesting discussions. But if you said the cutoff is 5 on a measurement, I would take that to 6, 6.5, because you can make the atrium a centimeter less in that diameter by taking generous bites in your close of the left atrial incision. I think to begin with, Stephen is correct, and you should stick to it. The other things to look at is length is also in AF is also variable. But if you look at the ECG and you've got decent voltage fibrillating waves, that is also a good sign of a reasonable outcome. However, as Steve's alluded to, there's another reason why I operate on large atrium and decrease them in size. They often have a right atrium that's beating, so you can see that with fibrillating F waves in the V1 and V2. So you can put them into sinus rhythm, but the left atrium will never beat. And this is a heart failure principle. So if you have a big left atrium on an MRI scan, the blood is swirling around. If you make the atrium smaller to a similar size that will accommodate on ventricular diastole, you have less stasis. So a combination of making it smaller and clipping the appendage, you'd less likely want to take these patients off anticoagulation. They tend to be elderly, but the patients I've operated on feel much better with a sinus rhythm rather than an irregular rhythm. So that would be my answer. I don't know if the Cleveland Clinic have any other discussions with that, but it's not, nothing is black and white. And back to the time issue, once you speed up, the time added to the surgery is not that much. And those that have done heart transplants, and that was a long while ago, but I have fond memories, the back of the heart is no mystery. The back of the left atrium is no mystery. So removing parts of the left atrium is very straightforward. Edward, do you have any comments from that, from the heart failure point of view?
No, I think you've got a very good point there. I think it's easy to maneuver your way around. That's never difficult. I think that the point of the size is exactly what we believe in. We don't have one specific cutoff to size, and oftentimes you have one opportunity to try it. It's extremely unlikely you're going to actually have any hazard from actually doing it, right? So I think it's certainly worthwhile to commit to a full Cox Maze 4 and manage the appendage rather than not. Yeah,
I agree. I mean, my first few I did, quite a few I did, were cut and sew. And by definition, you're reducing the left atrium when you do a cut and sew. So that means, a 7 centimeter atrium will get down to 5 very easily. But that's a long time ago, and I don't recommend you start that practice again if you're familiar with the devices, which are much more helpful. So the third question we've got before we can add some more questions, but it's from Dunbar and Gargius, and it's probably to Syed Hassan actually. He said, would we, as in perform AF ablation in a patient with slow AF? Now, I'm sorry to bag on, but by definition, atrial fibrillation is fast. But you then correct it by saying that with a ventricular rate that's less than 60. So I'll ask Saeed there. I mean, I have some theories that reason why you would. My answer is basically yes, but that tends to be to most things related to AF ablation. But sorry, Saeed.
Yeah, thanks, Steve. I completely agree with you. I mean, often we see patients having catheter ablations who've got well-controlled ventricular rates, and that could be for a whole host of reasons. So, firstly, it may just be because they're rate controlled on medications, and
sorry.
that's bringing the rate down.
You cut out a bit there, Syed.
Oh, sorry. Can you hear me now?
Yes.
Yeah. So it was really I think the answer is yes, and I agree with you. Often these patients are on medications which are bringing their rate down. That's not a reason not to ablate them. Often, especially in elderly patients, they may have some sinus node disease, which is underlying all this. So it's not uncommon for elderly patients with AF, when you ablate them and they go back to sinus rhythm, that they're a bit bradycardic. And they may need a pacemaker, but the pathology of that is different. So in answer to the question, I don't think there's any reason whatsoever to not ablate someone with well-controlled, rate-controlled AF or AF with a rate of 60, because all the data supports treating it.
I think with if you're going to stick to persistent and paroxysmal, one, your operative times will be shorter, and it's a good learning curve, and you'll get better results. But you shouldn't skimp on the lesion sets. We haven't discussed that, but they're very basic for a paroxysmal AF, in my view, for a concomitant, because it's a completely different pathology, is a box lesion. You have to isolate the posterior wall, however you do that. I now, with the smaller atria, and I can demonstrate this in other meetings, but take the Atricure clamp and I just put it around all 4 pulmonary veins, on pump obviously, and I've done this and I test at the end, which also I think is useful. Not many people do this in surgery, but if we all ablate at the beginning, and if you test 30-40 minutes later, that's the ideal time to test intraoperatively. And if you don't have isolation, then you can repeat something. But testing is very good. The cardiologists do it all the time with very fancy colour flow mats, but testing for box isolation or pulmonary vein isolation is I think very easy and good practice. I don't know if anybody's got any other comments with that.
Can I ask a quick question, Steve and Edward and Stephen? So one of the discussions we often have at IMDT with our surgeons is, biatrial maze versus left atrial only ablation in someone, say, undergoing valve surgery. And so I'd just be interested to hear your thoughts on, we know there's an incremental benefit from doing right atrial ablation, but in practice, what would you recommend to, people starting or developing a surgical AF concomitant program? I guess that it's always a point of discussion we have.
I'll go first and that's in, but the least you should do is as much on the left side as possible. And Jim Cox is not on this call, so I can say, and he told me actually, I don't know why, but I can say if you leave the mitral isthmus lesion, he told me that if you don't get an ATAC or a left atrial flutter within the first 3 months, you don't get one. And I've yet to drink enough glasses of wine with him to ask him to explain his data for that. But he tends to be kind of right on these kind of things. And on the right, you can do the right with the heartbeat. If you cannulate the appendage, you do a lesion down there first, then put a purse string and do the SVC, IVC, and tell your cardiologist, well, I've left the isthmus lesion because it takes you guys an hour to isolate a right atrial flutter. So there are shortcuts, but I think the basis for mitral is different. I think if you've got mitral, I would be concerned at leaving both, because 9 times out of 10, if you've got mitral incompetence with AF and due to AF, you will have tricuspid as well. So I tend to do both full Cox maze in those, and I do all my ablation with the exception of the cryo lesion to the mitral annulus with the heart beating, including the right and the tricuspid annuloplasty. So there are ways, if people are worried about ischemic time, you can lower it. But with good management of cardioplegia, I don't think that's a big worry. But I started doing this with less and less cardioplegia just to prove the point and say, well, you can do it if you want and it doesn't matter. But sort of Ed and Steve can answer as well.
Yeah, I sort of agree with that. I mean, I think that we tend to be more aggressive with the biatrial lesion set surgically. I don't think it adds very much. We're very used to sort of bicavally cannulating, or the IVC cannula, of course, as you mentioned, doesn't have to be all the way down near the IVC. You can have it up much higher, and it allows you access very nicely to the right atrium for a minute or two while your cross clamp is off and you're reperfusing, and you do 3 or 4 minutes of lesion sets, and you get a full right atrial lesion set. So we typically do that. Of course, there's going to be times when you're not going to want to do that, and that's fine. I think it's, as you pointed out, it's easy for our EP colleagues to do a cavoatrial lesion at a later stage if necessary. But we tend to be more aggressive, and in response to the issue of and I think the reason that a lot of people are not doing concomitant mazes is they're worried about the added ischemic time, number one, or number two, they're a bit unfamiliar with the anatomy around the pulmonary veins. So I think that is sort of an area where with some education and some training and a few case proctorings, once you sort of understand that anatomy, it becomes very simple, and you can pass the clamp around either all 4 of them or 2 of them individually at a time, and it should be very, very straightforward.
Can I add to that? And I agree. Before Steve, if you do a tricuspid lesion, tell your cardiologist where it is. They don't know, and if they go and ablate the cavoisthmus lesion and you've done a tricuspid lesion, you're going to be isolating quite a chunk of the right atrium, which is not good. Yeah. The other reason I do a lot of things off pump with a heart beating at the end is reperfusion, and I won't dwell on the paper that said there was more pacemakers in biatrial lesions, but I put on very few pacemakers. I now deliberately don't put in any wires if at all possible with a maze, and I usually do it just put on an atrial wire if necessary. But the longer you wait for reperfusion, the more likely you are to come off in sinus rhythm. Sorry, Stephen.
No, I was going to agree with you both. A lot of years ago, I started just doing a left atrial lesion set. But the data is quite clear. There is an incremental benefit from doing a full biatrial maze. And to be honest, the right atrial lesions are the easy ones. It's one incision. You've got to snare the cavity. It's not such a big deal. And if you want to get sinus rhythm, I think you need to try.
Great. That's very much what I would expect to hear from experienced AF ablating surgeons. So that's good to know.
Any more questions from the audience, or I should? Oh, that's very. We got silence. No more typing. I mean, we could ask it. I was going to ask Steve, why do you think we've had such a low uptake in the UK? Because in the US, on from that AATS data, there was a big campaign. And I think Nevada has some slides that we've seen before where in mitrals, where it's now up 70% or more for AF ablation. I can't remember whether that was the STS or AATS or both databases. But it's so one, I'll ask Steve why we haven't, and two, I'll ask Ed how they managed to educate the entire surgical population of the US.
Thanks, Steve. I think, as Ed suggested just a few minutes ago, I think there's a combination of unfamiliarity with some of the anatomy. It's not that difficult, but those who don't do mitral valve surgery are not working around the back of the heart every day. Perhaps skepticism as to how often you can achieve sinus rhythm, and with just a little attention to this, you can get really good sinus rates. And then there's the perceived risk thing in terms of clamp time, perioperative risks, but the data are very clear. You can do this in a finite amount of time, with or without clamp. I clamp for the maze myself, and it does not increase the risk.
Yeah, no, I agree. And I think one of the advantages of the campaign here in the US was a focus on surgical fellows and residents. So early on, focusing on the fundamentals of the maze lesion sets and the anatomy, and hands-on seminars and working groups and whatnot to get them familiar. So once they head out into practice, their first year or two, that's something that they can actually bring to maybe an older practice that doesn't do those, and it's an advantage. It's a competitive advantage for the U.S. surgeon, who sometimes will potentially get referrals from certain cardiologists because they have that ability. So I think part of it is that, and it's really been you have to really congratulate Atricure on really going the extra mile, at least here in the U.S. I don't know what was done in the U.K., but in the U.S. with the education efforts to try to get people to understand how to do this.
Yeah, in the UK it's happening, but not at the same rate, unfortunately. But I would just side this, but those of you that are interested is, if the maze, whatever form you do, full Cox maze or part of it, doesn't work, they should still go to the cath lab. Because Side's probably done a Cox maze. They're exceedingly segmented, and it's usually just a little touch-up. And while the devices are great, they're not infallible. And with thick atria, you only need a few cells to get a breakthrough. And the ones, certainly with those of us that do the VAT AF procedures or any stage hybrid ones, they go to the lab, and it really is just a touch-up. But the full Cox Maze 4 is so segmented that it makes Dr. Hassan's life much easier.
Yeah,
Have you done any side?
Yeah, we've done a few, and you're right. It's sort of the debulking. A debulked left atrium and right atrium, is generally much easier to treat, and I think patients do well. Yes, they sometimes get more atrial arrhythmias, but as you say, with the lesion set that you do, it's fine.
Yeah.
And interesting, there's still this perception about pacemaker requirement with right atrial lesion sets, and even if you hear Jimmy Cox when he speaks, he says that there shouldn't be anywhere where you're putting the AV node at risk.
Well, I have a theory that you're more likely to put the AV node or the His bundle at risk with putting a mitral suture in the wrong place at the wrong time, in the wrong direction. But it's interesting about the stage procedures, and I would urge people to really push this on, because Steve Bolling once said at a meeting that he tells people when he's consenting them for a Cox Maze 4 that's just the start, and they may need something else. And warning patients, as you guys in the lab with any ablations, you don't tell them, well, we'll get it, we'll fix it now, and that's it, you'll never need anything again, because you don't know until the lesions have matured. And that's the same with the ablations. I mean, the cut and sew data from Ralph Damineo and Jim Cox with the cut and sews is obvious, because if you cut through the muscle and you sew it back together, then you have a full thickness lesion. But while the RF clamp is brilliant, it's nothing like that will be infallible, and it will be just a small effort in the cath lab.
Yeah.
Is that your practice in Cleveland, or Steve in Wolverhampton?
Yeah, it is. I mean, we have an advanced atrial fibrillation clinic that we follow patients who've had concomitant maze procedures. So last year we did 420 concomitant mazes as part of our surgical practice. So all of those people get follow-up with our EP colleagues. Now, some of them obviously don't come back because if they're coming from far away or other countries for surgery, they may not want to come back. But many of them do, and they have been coming. And exactly as you say, they get some touch-up. And we're able to convert a lot of initially failed, Cox-Maze IV concomitant procedures with a bit of touch-up in the EP lab. And I mean, I tell patients, I don't tell them it's just the start, but I say that I'm Michelangelo. I got the big brush strokes for my ablation, and the EP lab, they're Picasso. They're doing the small little dots. And but you got to work together to get a nice painting and to get a nice result. You got to be able to do both, and that's where the success lies.
In answer, in my practice, yes, of course, some of the mazes may get recurrent dysrhythmias. If you have a gap, quite frequently what the patients get is a really troublesome flutter. And my EP colleagues have been in to touch up a number of cases with good results.
There's another question just coming quickly. It's probably for all of us, but from Louise Wiley Lau, who's asked a question about how do we record all our data, because in the unit she's set up a program follow-up at the center, but she's struggling with an effective way to record this. Steve, you've done a lot in the UK, and I'm sure in Cleveland you have an excellent follow-up clinic, but sort of Steve first and Edward, if you've still got time. You've not been called yet, so we'll keep you for this is the last question, but feel free to leave whenever.
So data collection in our unit is not quite as regimented as I would like it to be. We collect all the perioperative data on a dendrite database, so that's all very clear. We have relied on repeated audit cycles to know the outcomes of our ablation, which have been very gratifying. But I think there's place for an AF clinic, as you suggest. I think your numbers are probably a large proportion of the UK numbers, in fact. So an AF clinic would be ideal. Having a database would be great. There are issues in generating it in our particular institution.
And in Cleveland?
Yeah, we have an AFib tracker, which is a database collection tool that collects preoperative data, quality of life data, as well as all the perioperative data. It started actually, and then obviously postoperative data, including quality of life data. It started with the EP team. They are the electrophysiologists are the one who started this. Bruce Lindsay started it probably a decade ago, and we only started adopting this about a year and a half ago, surgically, to gather all this data. And I think it's important to have, all the discrete variable data as part of the operative record, but it's also valuable to get pre and postoperative quality of life data. And now we're finally having some longer term surgical data as part of this quality of life data collection. So I think it's critical. I think it's extremely important, and it will certainly help advance the field, because we've sort of had a device now and a Cox-Maze IV sort of lesion set that's been approved for use, so to speak, and everyone has adopted into their practice, but we haven't collected the data before that.
Yeah, just going on from that, I think we're trying to do the same in the UK, and I completely echo your comments. With the registry data, we're trying to hopefully start collecting across sites in the UK. We were doing something called the Track AF registry, which allows us to try and record the concomitant data and the convergent data. And I think that, as you say, it's the outcome data that we need to demonstrate, and that's the sort of initial step.
Yeah, thank you. I think while we start a lot of data collection, it got bogged down in assessing the surgeons rather than getting lots of data out of it. And I think that's going to open up a bit more in the UK. And we can link with readmissions through HES. HES is not as tidy, but there's lots of work we could do better. But I think it's up to most units individually to set up their follow-up, unfortunately. If we can have a national database that we could collect the same data set and send it to in the same way as we do with all the other data, and that would be wonderful. But yes, we're a long way from that in the UK, unfortunately. But it's an individual unit endeavour, I think, at the moment, by and large. So I think we may have finished all the questions, and there's there
was one more, Steve, about
audience.
post-operative management.
Sorry, I missed that. Where was that? Oh, sorry, Dunbar again. The post-operative management of patients after AF ablation is often not stressed enough. How do you manage your patients? Well, shall we start with Edward again in case he gets cold to you? Or
No, thanks. I'm actually going to head off there in a second. But our post-operative management, we restart anticoagulation usually for 3 months, unless there's a distinct contraindication after clip placement. We usually continue them on their antiarrhythmics, Ticasin being the only one that we sometimes don't continue. I think the key is to have follow-up. We get follow-up at 3 months. We send them a Zio patch. Patients have a Zio patch that they then telephonically send us the information. And we collect that data and determine the next steps. So I think that after a surgical ablation, you obviously have the issues with post-operative, post-surgical AFib, which is oftentimes a different substrate than the AFib that you originally came to the operating room with. So trying to differentiate those two oftentimes becomes challenging. So we usually don't differentiate, and we just wait the obligate 2 or 3 months.
Steve?
So I, provided they're not bradycardic, I try to give them amiodarone postoperatively, very much like NIVAD's protocol, which is published. It's out there for everybody. So amiodarone until first follow-up. I try very hard to get them into sinus pre-discharge. So if they have atrial fibrillation on the admission of their ablation, I would try to shock them before discharge. When they return, if they're in sinus, I'll switch them to a beta blocker. I anticoagulate from the day of surgery, initially with warfarin, and then switch them to a DOAC at 3 months. I'm aware that in North America, generally anticoagulation is stopped early, but I know that our cardiologists are extremely nervous about that. At present, I tend to reassess at 12 months with a prolonged Holter and an echo to look for atrial transport before stopping anticoagulation.
Great, thanks. I think Edward's obviously got to go, but one quick question before you go. With regards to post-op AF, which you said is a different animal, with the so we hear the US drive to decrease opiate use. Are you increasing your steroid use? Because the only trials in the past that have shown any difference in post-op AF involve steroids.
Yeah, we have not used, at least here at the Cleveland Clinic, we have not used any more steroids. But I think, a lot of the post-operative AFib can be managed, or at least you can decrease post-operative AFib with appropriate and judicious fluid administration, drainage of the pericardium appropriately. So I still think we don't understand it, obviously, very well, but we still struggle with probably a 15% or so rate of post-operative AFib on all cardiac surgeries.
Yeah. Well, I'd like to thank you before you go off, before I ask
Thank you, guys.
Thoughts, and hopefully we'll meet you in the UK or maybe in Barcelona, and you can drink wine with us rather than have to rush off to the OR.
No, that would be great. Well, thanks for the invitation.
Thank you very much.
Bye,
Thank
guys.
you. Sai, do you have any comment to add with follow-up?
No, I think what Steve has said is right. I mean, this concept of atrial transport is really interesting. I think it's important. I think, as Steve has also said, all guidelines currently recommend that anticoagulation is carried on. But, if you've got someone with a relatively low CHAS VAS score who's maintained sinus rhythm for a year, I think that's out. And the other interesting thing is with a atrial appendage occluder, as we've discussed before, is there a need for ongoing anticoagulation, and maybe that data will emerge in due course.
Well, the LAAOS III that shows that anticoagulation was additive, but obviously there was a huge number of patients who didn't have an ablation. So the sub-studies will be, and I've seen the data for the sub-study preliminary, but I don't think AF made a difference. AF ablation made a difference to stroke, but they haven't looked at any other issue, any other complications. But obviously bleeding risks as people get older is an issue. But I personally, I think AF is more related to the initiation of heart failure and problems in the future rather than stroke per se. But shall we, unless anybody else has got any burning questions, we've no more come in, and we have been watching. Dumbo was the last one, was it?
Yeah. I think that's
so I'd like to thank all the speakers and all the people who signed in this evening. This is a very interesting topic, and it will go on for quite a while. Hopefully we'll have the same accelerated process of concomitant ablation that they had in the US, and now we can travel and meet. Hopefully we can increase the education programs. So thank you very much, and we'd like to also thank you, Atricure, for supporting this and doing it under the auspices of the Society of Cardiothoracic Surgery. Thank you, guys.
Thanks, everyone.
Thanks, Steve.
Thanks, Stephen.